Welcome, dear attendees of the Alzheimer Europe conference on this featured symposium on dementia and migration or ethnic minorities. I'm glad that you were able to join at 10:45, and I think this will be a fascinating session with 5 excellent speakers. It is a DZNE sponsored symposium, as we were conducting a project on the EU Atlas on Dementia and Migration and are in the final phase in disseminating our results. So what's happening in this session is that my colleague Jessica Monsees, who's the first speaker, will start to present the EU Atlas, followed by Tim Schmachtenberg, who did more deeper literature analysis on the situation of people with dementia and migration in Europe, and followed by Maria Cardona from the DZNE, who is talking about expert interviews she was conducting in the framework of the EU Atlas. But the special thing today in this symposium is that we, with the EU Atlas, give a certain general state of the topic in the EU, dementia and migration, and add more expertise from specific countries to this. So we have Marco Canevelli, who is a research associate at the Department of Human Neuroscience at the Sapienza University Rome and at the Italian National Institute of Health, to give a very in-depth perspective from specifically Italy. And in the end, we are coming even more to the people themselves by inviting and letting speak Peter Bekkhus-Wetterberg from Norway. He's mainly a clinician at the University Hospital in Oslo and has the full-time position there. So I think this is a pretty nice roundup of the whole issue of dementia and migration in all its shortness, talking about all Europe we can handle in about 90 minutes. If there are questions arising through the course of the symposium, please use the question and answer section. We can see this on the screen when you ask a question, and we will include them in a discussion. We will have enough time for discussion. I would say we have a short 1 or 2 questions after each presentation, and in the end, the whole discussion. So let me introduce the first speaker, Jessica Monsees, please. It's your turn.
Yes, my name is Jessica Monsees, and as René said, I was part of the EU Atlas on Dementia and Migration. And yeah, I don't want to make it too long. I'm a psychologist. I work as a doctoral researcher at the Deutsches Zentrum für Neurodegenerative Erkrankungen, and I'm going to start off our presentation on the EU Atlas. And if we can start the video now, then we can dive into this topic. Hello, everyone. My name is Jessica Monsees from the DZNE in Greifswald, and my colleagues Tim Schmachtenberg, Maria Cardona, and we are going to present you with some of our main results from the EU Atlas on Dementia and Migration. This is a project that was funded by the Robert Bosch Stiftung and that we have been working on for the past 2.5 years. And first, we want to start with giving you a little bit of a backstory to this project and to the topic before we then go over to presenting you with some of our main results. And at first, there was this idea of the Robert Bosch Stiftung to generate more knowledge on dementia prevalence in people with a migration background in the different EU countries. And we applied to do this, we were chosen to do it, and then we got together, we brainstormed and developed this idea further. But why is this topic so important? What we can see from the literature is that people with a migration background with dementia are a subgroup of special vulnerability in the population of people with dementia, because they do not only face the dementia-related challenges, but they could also be facing additional challenges. For example, because of language barriers, or because they might not be familiar with the healthcare system in the country that they're living in, or dementia might be underdiagnosed. So we can assume that a large proportion of people with immigration background with dementia is not receiving the best care that is available. And although there is more and more research going on in dementia and migration, it is still a rather under-researched topic. For example, we are not really sure how they're being taken care of by the healthcare systems in the different EU countries. And also dementia is increasingly acknowledged on a policy level, but we don't really know how people with immigration background are considered, for example, in national dementia plans. And this is where our project comes into the picture, because what we set out to do is to estimate how many people with immigration background with dementia live in the different EU countries, but also the EFTA countries and the UK countries. We wanted to know where were they born and where do they live now. And another thing we wanted to analyze is how this topic is acknowledged on a guideline and policy level. And we also wanted to analyze how the healthcare systems and the healthcare services consider people with immigration background. And we did this to raise awareness for this very important topic. We want to encourage further research, of course, and we want to provide information to stakeholders, to policymakers, and to people working in the field of dementia and or migration. And the first set of results that we want to present you is our estimations on the number of people with migration background with dementia. What we did is that for each EU, EFTA, and UK country, we obtained data on the number of people with migration background, age 65 or older from different countries of birth. And also for each EU, EFTA, and UK country, we obtained age-specific dementia prevalence rates from the World Alzheimer Report and applied these dementia prevalence rates to the people with migration background. To make this a little bit more clear, what we did is that, for example, for people who were born in Algeria, are 65 years old or older, and who live in France, we applied the dementia prevalence rate of France to the people born in Algeria. And we did this for the country as a whole, but also for the different NUTS2 regions of a country, if they exist. The NUTS system, just in case you're not familiar with it, I'm going to explain this very shortly. The NUTS system is a classification system that divides the countries of Europe into 3 different levels, the NUTS level 1, 2, and 3, starting with larger areas in level 1, going to smaller territorial units with each level. After we estimated these numbers, we also wanted to visualize these estimations. So we created different types of maps in 2 different categories. The first category is the absolute number of people with migration background with dementia. And first, on a European level, we show an overview over all the EU, EFTA, and UK countries. And then on a national level, we show the 5 most common countries of birth for each country. And in the next step, for each of these countries of birth, we show where they live. And on a NUTS2 level, we also show the 5 most common countries of birth. The second category is the proportion of people with migration background with dementia per 100,000 inhabitants, age 65 or older. And here we also show an overview on the European level over the EU, EFTA, and UK countries. And then on a national, as well as the NUTS2 level, we show the 5 most common countries of birth. And as I said, the first category is the absolute number of people with migration background with dementia. And all over the EU, EFTA, and UK countries, we estimate an absolute number of about 531,000 people with migration background with dementia. And in this map, you can see the absolute numbers for each country. And the darker the blue, the more people with migration background with dementia live in the country. And we estimate the countries with the highest numbers of people with migration background with dementia to be Germany, France, the UK, Switzerland, and Spain. And all over the EU, EFTA, and UK countries, the migrant groups that are estimated to be affected by dementia mostly originate from Italy, Algeria, the Russian Federation, Germany, and Poland. And as I said before, on a national level, we show the 5 most common countries of birth. And in this case, for Romania and the people with migration background with dementia, they seem to be mostly originating from Hungary, Germany, the Ukraine, Serbia, and Slovakia. And for people who were born in Hungary and are estimated to have dementia, you can see here where they mostly reside in Romania. And they mostly reside in Northwest, Central, West, and Bucharest. And on a NUTS 2 level, we also showcase the 5 most common countries of birth. And what we can say here is that the countries of birth, they can differ from region to region. For example, in Northwest, we have Hungary, the Ukraine, Germany, and Slovakia as the most common countries of birth, whereas in Südest, it's Romania, Turkey, Greece, the Ukraine, and Hungary. Another thing that we can see here is that, for example, Hungary as a country of birth shows up in every single one of these regions, whereas a country like Poland only shows up in one region. The second set of numbers is the proportion of people with migration background with dementia per 100,000 inhabitants, age 65 or older. And here you can see again this overview over all the EU, EFTA, and UK countries. And in this map, it's the same. The darker the blue, the bigger the proportion. And if we look at these set of numbers, we can see that there are different countries showing the highest estimated numbers. And the countries with the highest estimated numbers of people with migration background with dementia per 100,000 inhabitants, age 65 or older, are Liechtenstein, Luxembourg, Switzerland, Latvia, and Estonia. If we go over to the national level of a country, we can now say here for Romania that there are 293 people who were born in Hungary and are estimated to have dementia. Or there are 10 people who were born in the Ukraine and are estimated to have dementia. And in this last map that we want to show you, we can see this proportion for each of the NUTS 2 regions. And we can say that the size of the pie chart also indicates the size of the proportion. And it's basically that the bigger the pie chart, the bigger the proportion of people with migration background with dementia is per 100,000 inhabitants in that region. And for example, we can say that for a region like Central, the proportion of people with migration background with dementia per 100,000 inhabitants, age 65 or older, is bigger than in regions like Nordest or Südwest Othenia. And overall, what we can take away from these estimations is that people with a migration background with dementia, they are not just a group of special vulnerability, but they are also a group of a significant size. This further confirms the fact that we have to take care of them and that we have to acknowledge them and consider them in different levels of dementia care. And how they're being considered on the policy level is something my colleague Tim Schmachtenberg is going to present you now.
Thank you, Jessica, for this brief introduction to the EU Atlas and the first numbers. If there are questions, please feel free to use the chat and the question and answer section. We can answer those questions. One thing I might, before we start, I will go over to Tim is, why did you choose Romania as the country with you presented here?
Because, I mean, the main reason is because it was ultimately was supposed to take place in Bucharest, so we thought would be perfect to use Romania as an example. But of course, each country would have been extremely interesting to see. And yes, but like I said, we chose for this conference Romania.
So there's not a special, that's not a special focus on Romania, something special, just that Alzheimer Europe was supposed to be here. Okay, and so yeah, read the atlas then for the other countries you're interested in. If you, there's the first question. Is this EU Atlas available for every EU country already? It is available, and we will share the link and everything after the presentation and put it in the chat probably too. Exactly. Thank you very much, Jessica. And yes, we would go over to Tim Schmachtenberg to his presentation.
Warm welcome from my side. My name is Tim Schmachtenberg, and as Jessica said, we now continue with a summary of the chapter on the national dementia plans. Yeah, in this analysis, answers should be found to the questions how attention is paid to the relationship between dementia and migration, and whether specific actions are taken at a national level to ensure the care of people with a migration background with dementia. Yeah, and on the next slide, you see an overview of the chapter of the methods of this study. And to get answers to the question described, a qualitative discourse analysis of the national dementia plans and strategies of EU, EFTA, and UK countries was conducted according to the model of Rainer Keller. The online platform of Alzheimer Europe and the search engine Google served as a database for the documents. These databases were screened on 2 dates, the 1st of June in 2019 and the 4th of January in 2021. And as a result of the screening, the data corpus comprises 13 documents. Next slide, please. And these documents were systematically screened for their relevance to migration. The first step was to examine whether the documents include separate chapters on migration. And then the national dementia plans were screened for K terms such as minorities, migration, culture, ethnic background, or migrant. This means that ethnic, language, and cultural minorities were also considered in studies, as migrants are often part of these so-called groups and are then no longer explicitly mentioned. In national documents on dementia care, many different terms are used for people with a migration background, which we have tried to identify as completely as possible by using this large range of keywords. If the migration topic was found, the content analysis of the section in which it was located was carried out. For this purpose, the contents were paraphrased, memos and comments were added, and text passages were coded using the strategy of open coding. Afterward, the results were interpreted and assessed. And then we come to the next slide, the results of the analysis. And based on our search, 18 of 27 EU countries, all 4 EFTA countries, and the 4 UK countries have national dementia plan or strategy. Of these 26 countries, 14 countries address migration in their documents. A separate chapter on dementia care for people with a migration background is only included in the Austrian dementia report and the German dementia strategy. The majority of the other national dementia plans address the topic only briefly. The content focus of the sections on migration was primarily on the description of challenges such as cultural and language barriers, late diagnosis, and low utilization of care services. Overall, 10 countries refer in their national dementia plans to planned measures to care for people with a migration background. And their attention should be paid to the conception of tailored information materials, training of caregivers, and the development of language and culturally appropriate diagnostic tools. And on the next slide, you see a map, and on this map, you see that only the documents of Germany, the Netherlands, Northern Ireland, and Norway refer to available services for migrants with dementia. The German dementia strategy refers to various counseling services tailored to people with a migration background with dementia and their relatives. And according to the Dutch document, special attention has been paid to in the early detection and prevention. And Norway's dementia plan cites a project completed in 2020 that adapted test procedures for assessing cognitive abilities and dementia symptoms to foreign languages. And overall, this analysis has shown that the topic of migration plays a subordinate role in most national dementia plans of EU, EFTA, and UK countries. And then we come to the second document study. And this was an analysis of national treatment and care guidelines, policies, and recommendations on dementia with regard to people with a migration background. And these documents were obtained with the help of national Alzheimer societies, national health or social ministries, and different professional societies. And these organizations were contacted by email in the period from the 2nd of May to the 11th of July in 2019. And after that, responses were received from 47 organizations of 35 countries, and thus it was possible to create a profile for each EU, EFTA, and UK countries. Next slide, please. And to integrate documents from as many countries as possible, no definitions or restrictions were made. And besides, a Google search was for this analysis was then 43 documents. To structure the very heterogeneous corpus, the documents were assigned to the standardized categories, policies, guidelines, and recommendations. Yeah, and according to this survey, And on the next slide, you see that 20 of 27 EU countries, 3 or 4 EFTA countries, and all 4 UK countries have documents with national recommendations, guidelines, or policies for the care of people with dementia. 15 documents from 7 EU countries, 4 UK countries, and EFTA country Norway discuss the topic of migration. But only Norway and Sweden have a chapter on migration. Most of the other countries refer only briefly to specific aspects of this topic. The thematic focus of the documents is on early detection and diagnosis. The main challenge identified is that the cultural background and language skills of people with a migration background can influence the results of dementia diagnostic tests. Next slide, please. And consequently, the content focus in most countries is on the suitability of cognitive screening tools for people with a migration background. 9 countries provide recommendations for the care of migrants with dementia, and several countries recommend that the linguistic and cultural background of people should be considered when selecting diagnostic test procedures. And on the next slide, we have a map. And on this map, you can see that only Norway, Sweden, and Denmark refer in the guidelines to available healthcare or diagnostic services for people with a migration background with dementia. Norway cited published information material on dementia in 4 different languages and a brochure with information on the provision and use of professional interpretation services. Sweden and Denmark point out that the intercultural dementia screening tool RUDAS, the Roland Universal Dementia Assessment Scale, has been validated for people with a migration background. And overall, this analysis shows too that migration plays a subordinate role in national dementia care guidelines. And then on the next slide, we come to the conclusions of these 2 document studies. And the document studies have shown that 90 documents on the care of people with dementia were considered in this analysis, of which 13.8 count migration references. The proportion of national dementia plans has increased slightly due to the integration of documents published in 2019 and 2020 in the corpus of the study. But migration is still a minor topic in the national dementia plans, strategies, and guidelines for the care of people with dementia in most European countries. Yeah, now after giving you an overview of the extent to which the topic of migration is considered in documents on national dementia-specific care planning, Maria will explain how the situation is in practice in different European countries.
Well, thank you a lot, Tim, for this more in-depth presentation. We lost Tim somehow during our session, so he's not able to answer questions at the moment. If there are some, Jessica and Maria are very well trained and knowledgeable too about the questions, but I would like to hand over to Maria now, as Tim was having this literature-based, this more official overview on the guideline level. Maria went more into detail and interviewed experts. Maria, your presentation, please, and short introduction by yourself.
Yes, so I'm Maria Cardona. I'm a Colombian psychologist, and I'm also a doctoral researcher at the German Center of Neurodegenerative Diseases in Greifswald, Germany. And one of my research focus is dementia and migration. And now I would like to present you the interviews we conducted within the EU Atlas project. So now we can present and run the presentation, please.
So for the final stage of the project, in addition to the previous work presented, it was decided to conduct qualitative interviews with experts on the topic dementia and migration, and this was done to obtain further views on the topic and also to receive in-depth responses on how the care situation looks like in practice among persons with dementia and with migration in the different included countries. So as we can see in the next slide, please. The original plans for the interviews was to visit the experts in their respective countries and do the interviews face-to-face.
Okay, so as we were saying before, for this final stage of the project, in addition to the previous work presented, it was decided to conduct qualitative interview with experts on the topic dementia and migration. And this was done because we wanted to obtain further views on the topic. So we also wanted to receive in-depth responses on how the care situation looks like in practice among persons with migration and dementia in the different included countries. So the original plan for the interviews was to visit the experts in the respective countries, but due to the COVID-19 pandemic, we have to change our format, and then we switch to video conferences, and then we implement them over the course of 12 months. So then in the next slide, please, and also the next one. Then here we can see a little bit like to understand better like what we did. I want to explain you the methodology we implemented in our interview. So in the next slide, we can see that we conducted qualitative semi-structured interviews, and we explore 5 main topics. So we explore general aspects of persons with migration and dementia. We also explore care for persons with migration and non-migrants with dementia. We explore inclusion and information of persons with migration and dementia. We explore professional care and also support for family caregivers. On the next slide, we can see that the primary source to develop our interviews, we design our questions based on the Alzheimer Europe report from 2018. And also we use other sources, such as scientific articles, national and international reports, and also national dementia plans. On the next slide, we can see that the language we use was in English in most of them, and we have 3 exceptions: Germany, Liechtenstein, and Luxembourg. They were held in German. And also in the next slide, we can see that the participants that were included in our project, they were experts who were researchers, they were also care planners, they were care providers, and also some of them were representatives of the dementia associations, or also like representatives of Alzheimer's societies. And finally, in the next slide regarding the methodology, we can see that the data analysis we used was procedures of qualitative content analysis. So in the next slide, Jessica, we decided like to design an interview guide that included the 5 previous topics that I mentioned before. And then this interview guide was sent to the experts. And together with this document we sent to the experts, we also sent them like the key definitions of the key terms we were using in our guide. And then we also sent them the proposal of the whole research. And here we can see some of the examples of the questions that were included in the interview guide. So for instance, we can see one of the questions was, how important is the topic dementia and migration regarded in your country? In the next slide, we can see another question that could be that it was, which specific and or specialized healthcare services are available for persons with migration or for people from certain ethnicities in your country? Another question on the next slide, we can see how widely available are information services for persons with migration, with dementia, and their family members in your country. Another question, also in the next slide, was, is culturally sensitive care part of the professional qualifications? And on the next slide, we can see the final example of the guide. And one of the questions was, how high do you estimate the need for specific information and services for family caregivers of persons with migration and dementia? So considering that that was our guide and some of the questions we posted, now we want to show you the results we obtained. So we can see as a result from our interviews that we conducted interviews and discussions with 26 experts for a total of 17 countries. Also, these countries, you can see them there. The countries we included, you can see them there in the square. Some of them were Austria, Belgium, Bulgaria, and so on. And on the following slides, I will highlight some of the most remarkable points extracted from these interviews. So the first topic, as I told you, like the experts were asked about some general questions about dementia and migration to be able to classify the relevance of the topic in their respective country, and also to determine the priority it has in the national healthcare system, as well among regional care planners and service providers. So here, as a result, we can see that only one country, in this case was Austria, they consider dementia and migration as a serious concern at a national level. Also, we can see that persons with migration, they are identified as a vulnerable group in healthcare in all the countries, except in one. And also in the third and last one graph, we can see that there are twice as many countries whose health system never treat persons with migration and dementia and their family members as a group with a specific needs. In the next slide, we can see here like all the questions we did and the answers regarding care for persons with migration and non-migrants. And here we primarily focus on the availability and suitability of formal care services. So we can see in the different graphs that just over a third, so 6 countries, they have nationwide or almost nationwide coverage of specialized services in outpatient and inpatient care for persons with migration and with dementia. And also this graph, the last graph, shows that in less than a third of the countries, the existing care services are adequate for people with dementia, with and without migration background. In the next slide, the category was inclusion and provision of information. And here we wanted to see the degree of inclusion of people with migration in dementia into the healthcare system. And the graph is showing us that almost 2/3 of the countries, this population is either only slightly or not at all included into the healthcare system. The next question we also posted was regarding professional care. And in this section, the experts were asked to assess the proportion of professional caregivers with a migration background in outpatient and inpatient care, and whether the need for culturally sensitive care was met by sufficiently qualified professionals. So we have 4 graphs, and in the first 2, we can see that almost half of the countries it's estimated that the proportion of professional caregivers with a migration background is high or very high in both in outpatient and inpatient care. And in the other 2 graphs, we are assessing the need of culturally sensitive care, and we can see that in the majority of the countries, this need is not being met by sufficiently qualified professionals. And finally, the last category is support for family caregivers. And in the last section, we asked the experts about current differences in the provision of information and support services for family caregivers of people with dementia with and without migration background. So we can see that in most of the countries, either minor or rather minor differences were found. So in this way, as a conclusion, like in the next slide, we can say from the interviews, also in this slide, thank you, that there is a great lack of attention in society, also in care policy and science regarding dementia and migration. And besides, the topic is not declared as an important in the healthcare system of the countries included in this study. As a result, in most of the countries, the experts identified that either there are no specialized services for persons with migration and with dementia, or if these services exist, they only exist in individual regions. And also this lack of services is partly problematic, as in 14 out of 17 countries that we included. And there is either a very high need or a high need for such specialized services, according to our experts. So in the next slide, I will also like to say like a conclusion about the project, like an overall conclusion. And we can say that persons with migration and dementia, they represent a large and heterogeneous group in Europe. Also, migration plays a subordinate role in national dementia plans, and that more inclusion and also more improvement in current healthcare system is needed, as well as an improved intercultural care in inpatient and in outpatient care settings. In the next slide, finally, we can say that even though our findings are valuable, it's important to interpret them with caution, since its validity is describing the real situation, but is limited to the number of sufficient experts, for example, we included in the interviews. Also, better data is needed at all levels. And finally, we can say that the EU Atlas project is not like a benchmark that defines what is appropriate and what is not. So this is the presentation we have. And thank you so much for your attention. And we're so sorry for the inconveniences. And I hope we could manage to solve them.
Okay, thank you very much, Maria.
Yes.
Now, this was a quick overview about the whole project, about the EU Atlas, and the caution sentence was spoken. And I'm glad that if you paid attention, Italy was marked with the health system is not prepared by expert opinion. And the thing is, Marco Canevelli, our next speaker, will be from Italy, having much better data and more in-depth analysis on this. Please, Marco, it's your presentation.
So thank you. Good morning, everyone. It's a great pleasure for me to have the opportunity to present and discuss the findings of the IMIDEM survey that aim to characterize the issue of cognitive disorders and dementia in international migrants living in our country from the perspective of Italian services. I have no competing interest to disclose. The IMIDEM was funded by the Italian Ministry of Health. And so due to the increase of international migration and the progressive aging of the population, the number of older migrants living in Italy has shown a fourfold increase in the last 3 decades. As you can see, it passed from 200,000 to almost 4 times in 2020. And this demographic transition is, of course, coupled with an epidemiological transition and with important changes in the health needs of migrants living in our country, as it can be expected that they will increasingly deal with the burden of age-related chronic diseases. And this, of course, will imply important clinical and social implications. And more specifically, as reported in the EU Atlas on dementia and migration, nearly 20,000 cases of dementia in people with a migration background can be estimated in Italy. And so, as recently pointed out by important public health documents and recent papers, there is the need to collect real-world information on the dimension of this emerging problem and on the preparedness of healthcare services to promote the inclusion of all vulnerable groups, including migrants, in the public health response to dementia. And so our study aimed to estimate the number of migrants attending Italian memory clinics that are called Centers for Cognitive Disorders and Dementia, and to identify potential barriers and facilitators or resources in the provision of care to these people. And so we designed an online questionnaire to obtain information on the number of migrants attending Italian memory clinics in 2019. Of course, we had to rely on 2019 data because of the COVID-19 pandemic that subverted the activity of CCDDs in Italy. And we also collected data on the adopted cognitive assessment tools for the evaluation of migrants and on possible barriers and resources in the clinical approach and management. And then this questionnaire was tested in a pilot survey involving a representative sample of 24 Italian CCDDs to ensure that the questions were clear to the respondents. And then the findings of this pilot survey were discussed into 2 focus groups involving healthcare providers with experience in the field of migrants' health to further refine the questionnaire. And finally, a link to access the questionnaire was sent to all the CCDDs mapped in the Dementia Observatory web platform of the Italian National Institute of Health. And we adopted different strategies to enhance the participation and maximize the response rate. And for instance, participants were contacted by initial and follow-up emails, and they were also offered telephone support if required. And overall, you see on the map how 343 out of the 570 eligible CCDDs completed the survey questionnaire. So the national response rate was high, was more than 60%, and ranged from 21% in the Puglia region to 100% in Molise, Friuli Venezia Giulia, and Val d'Aosta. So just to provide a regional detail. And based on the information provided by the representative of these CCDDs, nearly 4,500 international migrants attended these services in 2019, with a median number of visits and neuropsychological assessments per CCDD equal to 5 and 2 respectively. And so migrants accounted for about 1% of overall visits and cognitive assessment in this sample of memory clinics. And a higher number of migrants were observed in the northern and central regions relative to the south of Italy. And more than 1/3 of respondents reported that the number of migrants attending these services had increased in the last 5 years. And nearly 75% of services had visited at least one migrant in 2019. And a north to south gradient was documented also for these variables. And with regard to the possible resources for the provision of care for migrants, just a minority of CCDDs had information material on dementia in languages other than in Italian. They had translated cognitive tests or the availability of interpreters or cultural mediators, while most services reported the possibility to activate social care workers. And in most services, staff members spoke at least one foreign language. And again, unfortunately, CCDDs operating in the north of the country seemed to have more dedicated resources as compared with those in the center and in the south of Italy. And respondents were also asked to indicate which cognitive tests were used in their services for the assessment of international migrants. And most services adopted only screening instruments assessing global cognitive performance, such as the mini-mental state examination or the Montreal Cognitive Assessment, that have been shown to be strongly influenced by the cultural background of the tested individual. Concerning neuropsychological tests, there was a preferential choice of tests purely relying on language skills. And to assess the quality of the cognitive assessment of migrants, the tests and measures adopted by each memory clinic were evaluated in terms of 2 parameters that were the accuracy and the culture sensitiveness. And they were rated as low, sufficient, or good. And so an overall quality score was generated by combining these two aspects. And as shown in these graphs, just a few services adapted the cognitive assessment to the cultural background of the migrant. Only in a minority of cases, the cognitive assessment was substantially or sufficiently adapted to the culture of the tested person. And the most common adaptations were the involvement of informal or professional interpreters, the choice of nonverbal neuropsychological tests, and the assistance of a cultural mediator. Just 4 CCDDs, so the 1% of our sample, adopted instruments that have already been validated in multicultural populations, such as the aforementioned RUDAS and the cross-cultural dementia screening. And so the overall quality of the assessment was low or just sufficient in most cases, and was again higher in northern and central regions relative to the south. And exploratory models were also conducted to tentatively delineate the profile of CCDDs that have higher experience in the assessment of migrants and provide higher standards of care. And so the CCDDs receiving at least one migrant in 2019 were significantly less frequently located in the south of Italy, had more frequently registered an increase of the trend of referred migrants in the previous 5 years, and more frequently provided cognitive assessment of better quality to migrants. While the geographic macro area was the only factor that was significantly associated, inversely associated with the quality of the cognitive assessment. And finally, the main challenges encountered in the provision of care for migrants with cognitive disturbances were the communication of the diagnosis, the formulation of the diagnosis, and the involvement of family members, whereas the management of pharmacological treatments and neuropsychiatric symptoms were instead considered problematic or challenging just by a smaller number of centers. And it's interesting that nearly 1/4, so 25% of respondents, considered this issue of dementia in migrant as a priority for their clinical services. So in conclusion, the present study aimed to estimate the dimension of the issue of dementia among migrants living in Italy and to document existing discrepancies in the activity and preparedness of dementia services, and to identify those attributes, those determinants that may be associated with higher standards of care in these settings. And first, we found that a relevant number of migrants are already attending our CCDDs, and this survey provided an underestimation of the real number of migrants living with dementia in our country. In fact, an important proportion of CCDDs, 40% in the Italian scenario, did not participate. And moreover, only regular migrants who have access to the national health system are referred to these services. And so refugees, asylum seekers, and undocumented migrants potentially experiencing a cognitive problem were not captured by this survey. And in this regard, nearly 50,000 cases of mild cognitive impairment and dementia can be estimated in the migrant population living in Italy by applying age and sex-specific prevalence rates. So it's a number that is definitely higher than that was captured by our survey. And Italian dementia services seem to be not adequately prepared to deliver diversity-sensitive care and support. In particular, there is the need to develop and validate cross-cultural or culture-sensitive cognitive assessment tools, as recently advocated by the newborn European Consortium on Cross-Cultural Neuropsychology. And the role and activity of cultural mediators and interpreters should be clarified. And in this latter regard, the proportion of Italian CCDDs that are adopting interpreters is definitely very low. And we also documented important geographic discrepancies in the provision of care that might be partly be attributed to the different distribution of older migrants in the different Italian macro areas. There are just few older migrants that live in the south of Italy. However, we had already shown with 2 other surveys that CCDDs operating in the south have lower resources and less frequently provide a comprehensive neuropsychological assessment also to native Italians compared with national standards. And the main limitation of the study is that provide just a partial characterization of this phenomenon. As we mentioned before, not all migrants are captured by the survey. The main strength is, of course, represented by the very high response rate that was achieved to a close interaction with regional delegates, with healthcare districts, with individual healthcare professionals. And so this collaborative approach is crucial for creating a national identity and collaboration on this issue. And so it is important to federate IMIDEM with other similar initiatives ongoing in Europe. So I'm very pleased to participate to this session. And our data should inform sort of public health policies aiming at reducing the health inequalities and guaranteeing the highest standards of care and promoting the well-being of all people with dementia living in the country, regardless of their country of birth. So I would like to thank you for your attention and to thank all the members of the IMIDEM study group. Thanks a lot.
Well, thank you very much, Marco. That was a very good study and very helpful to get a deeper in-depth look at Italy and stating some of the problems we've seen too for the low utilization, but there is already utilization, so there's light at the end of the tunnel. And also that we're not talking about just migrants, very diffuse group. We're talking about health inequalities in the end. So, and I'm very glad that Peter can join the session, who is talking about the process of increasing awareness of the challenges of cognitive testing in ethnic minority groups, and is expanding this to people with low educational level as well in Norway. Please, Peter, start to introduce yourself and share your screen.
Okay. So this is my name. I work as a senior consultant in the memory clinic in Oslo University Hospital. I'm basically a clinician, but I have engaged in some research, which I will tell you about. And I'm also a member of the group that Marco talked about, the European Consortium on cross-cultural neuropsychology. I'll never remember the whole title. So my background is I'm a doctor, and I'm a specialist in geriatrics, and I've worked in different settings with dementia diagnostics and care for now almost 30 years. Sounds terrible, but that's the way it is. And I've been working at the memory clinic here since 16 years. So my main interest is diagnostic cognitive testing. That's sort of what I'm most interested in. So, and when it comes to immigrants in Norway, the largest immigrants groups here are actually people like me, because I was born in Sweden, but I'm working in Norway, and other Europeans who are mostly young adults coming here to work. For example, we've had very many people from Poland who work in the building industry mainly, and they are not people who we see in memory clinics usually. So our elderly immigrant populations are mostly Pakistani and Indian people who came here in the 70s to work. So they started working mostly in unqualified jobs in factories, driving trams and subway trains, working with cleaning, starting small shops and things like that. And they are now aging and becoming a larger and larger population in memory clinics. So around 12 years ago, there was a general realization that we didn't have any methods for assessing these people with when they came with their cognitive complaints, because doing our ordinary screening tests obviously didn't work with these people. Even if they'd lived for many years in Norway, they usually didn't have very much knowledge of Norwegian. And also, it was apparent to us that they had difficulties in performing these tests that we tried to do with them. And also, we didn't really know what the norms were for these tests in these groups. So what did a result of so and so many points actually mean in these people? So we have a very good system here in Norway. If you work as a senior consultant in a hospital, you get 4 months paid leave every 5 years, which you can then use to study or visit other clinicians or do a project of some kind. So my idea was to do a project trying out different cognitive tests on healthy elderly immigrants to see what the results were, because we didn't really know. And then our professor here at the clinic, he said that there is a guy in Copenhagen doing the same thing, called Rune Nielsen. So why don't you ask him? So I did, and it turned out we had many of the same ideas, and he was then working on his PhD project, testing Turkish immigrants in Copenhagen. So I adopted most of his test battery and started testing healthy elderly immigrants here. And I chose Punjabi speaking, so they can be either from Pakistan or from India. Initially I worked together with two medical students who were of Pakistani origin and spoke Punjabi and Urdu. When that's, well, they helped me with, say, 10 immigrants, and then the Norwegian Center for Migration and Minority Health started a large project on immigrants and dementia. And then they sort of included me as part of their project. So I was able to go on testing the healthy immigrants. And then these data were added with several others to Rune Nielsen's studies. He completed his thesis in 2012. And the work went on, and it's finally resulted in a normed and validated test battery, which is designed and suited for use in immigrants, where we have one long and one short version. And it's also designed for use with an interpreter, because that's, of course, also an issue. If you do an ordinary test with an interpreter, what does the result mean? Does it have the same validity as if you've done the test in the person's own language? But these tests were designed so that they were intended for use with an interpreter. And we also looked at, did the use of an interpreter influence the results, which it didn't. And so norms have been collected for all education levels from 0 and upwards. And these tests have been published. As you can say, these are some of our group's publications on these tests. I realized early on that I was one of the few people in Norway interested in this, but when I started talking to others, there were others who were interested and who saw the problem and also saw the need for spreading the news, trying to raise awareness about this problem. That because we knew from studies both from Denmark and from Norway that there is a tendency that older immigrants don't get dementia diagnoses, and younger immigrants tend to get dementia diagnoses, probably because they are being tested with ordinary cognitive tests and failing, and so they get a dementia diagnosis, even if they are 40 years old and obviously don't have dementia. So already in 2013, even though these tests were sort of in their infancy, we arranged an educational conference, educational event on immigrants and dementia, and invited all categories of health workers, and it attracted quite a lot of interest. So Norway is a small country, population-wise. We have about 5 million inhabitants, and actually 60 people working with dementia were interested in coming already in 2013, which we were very happy about. And the Norwegian National Directorate of Health started work on a national guideline for dementia in the same year, in 2013. And they had obviously picked up on this this educational event we had. So I and a few other people were invited to work on a section in the guidelines on immigrants and people with low education, because rapidly we saw that the main factor in this is education. Culture does influence results on cognitive tests, but education is the most important factor. So, and other ways of spreading the news, the Norwegian National Advisory Unit on Aging and Health arranges what are called the Dementia Days yearly. That's 2 days of conference, educational events, and so on. We who worked with this topic were able to be invited and have sessions on this theme, which we've had now for several years, not every year, but sort of every other year or something like that. Other arrangers of courses on dementia have included this theme of migration and dementia. And also the psychologists and neuropsychologists have started to include this theme in their educational programs. So I've been there several times and talked about this topic. And then this National Advisory Unit on Aging and Health were given the task by the Norwegian National Directorate of Health of publishing a handbook of extended dementia assessment, extended as opposed to basic dementia assessment. And this was published in 2020 and has a separate chapter on dementia assessment in people with a minority background, which I have written. And these are the chapters. You can see that there are chapters on different topics, and there is, as I said, a special chapter on minority background and a special chapter on Sami people, and also a chapter on assessment of people with intellectual disabilities. You can see that several of these, especially difficult patients to assess, have been addressed in these in this handbook, which is very nice. And then we had been using these tests for some years, obviously, because we started talking about them already in 2013. But then we have now made official translations of these tests and test manuals done in every possible with every possible precision and with cooperation of Rune, who designed the tests, and the people behind the RUDAS screening test. So we have now official translated versions of both the tests and the manuals, and these are all freely available from the National Advisory Unit, so anyone can acquire these tests and use them. So have we reached our goal? Well, no, we haven't probably. I think we've raised awareness, but this is an ongoing work, of course, and I still often get contacted by people in other memory clinics or neuropsychologists or from people working in the primary healthcare, asking me, what should I do with this patient? How can I assess them? What is the best way of doing this? And now it's very good to have these official guidelines. We have this handbook, and we have the translated tests and manuals which we can refer to, which of course is a lot better than what we had when I started this journey. But I think we have to go on doing this, and it's nothing you can do once and think that now we've fixed it forever. We have to go on working and go on having educational events, appearing at national congresses and so on. Okay, thank you.
Thank you, Peter. Very well done. And your presentation has raised some questions or need for clarification in the chat too, which is basically concerning the assessment. And I sum it up. If you mean all immigrants, when you talk about they are adjustable to different cultures, countries of origin, and where can you access them? Or can you access them? Are they freely available? Share a link. And very much agreement on that the spot on language, culture, and level of education is very much needed. So the tests, all immigrants.
Yeah, we've discussed that a lot. Because of course I also know many immigrants who are very highly educated and say that, well, I'm not sure we need these special tests and so on. But the problem is always that even if you're very fluent in a language, it's something else when you're tested with a cognitive test. It's not the same as working with a language or having a conversation in a language, because being tested is quite a different situation. I think you should seriously consider using special tests and interpreters when assessing people who are of another background. Because I mean, Norwegian and Swedish are very close. The languages are very closely related, and most Swedes can understand most Norwegians. But I've lived in Norway now for 26 years, and I think it's really during the last 5 or 6 years that I've fully mastered all the nuances of the Norwegian language. Even though I work with the language daily, and I'm very interested in languages in general. I think you should, in most cases, try using tests that are devised for using in different populations. Yes. And of course, the education level is the most important thing, so that the less education people have, the more aware you should be of using these special tests. And the tests are freely available in Norwegian, but that won't be of much use for you. But the Ruders is widely published and easy to find. And if anyone is interested in adapting these tests to their own language, you can always contact Rune Nilsson in Copenhagen or me, and I can help you with the contact. And I know that he is very interested in collaborating with anyone interested in doing the same thing in their country. Exactly. And two of the tests in the large battery are copyrighted. That's the color trails test and the 5 digits test. So those you have to buy from the publisher, but otherwise these are freely available tests that anyone can use. Yes.
Thank you very much. I think we're a little bit over time, but I think that's okay. There's one thing, yeah, I think one point Rune would make is, well, you need validated tests for your application area. So don't just take something and translate, please develop it. And it takes time, like you said, you're in this for a long time, and you're still trying to understand the whole heterogeneity and complexity of the whole issue.
Yeah.
I would then end the session perhaps with one question, because we're focusing a little bit on the assessment, but after the assessment, the treatment and care comes. And there was one question whether there are any examples of good practice in intercultural care that could be shared. And if, as a summing up, if someone of the panel would state something in this regard, it would be very nice. Any ideas, suggestions? Jessica?
Yeah, I could share something from our interviews with, or our interview with, for example, the Netherlands. They told us that besides using the Ruders for assessments, when it comes to care, they have some clinics have specialized daycare programs for people with immigration background, with dementia, where, for example, translators are always present and that are specialized for people with immigration background. Or there is a service that connects people with live-in care facilities. And when they get transferred to this care facility, this facility is also adapted to their needs. So if they want to, if they're only able to eat special food, they can get that there. If they want to live according to certain religious practitioners or something, they can also do that. So these would be a few models of good practice in care.
Any more additions?
Yes, I can just ask 2 examples also I remember from Norway. And one was called ABC Dementia Care. And this was designed in order to educate non-health professionals working in nursing homes. And here, like since 1 year ago, they added one module on dementia and immigrants. So they're also trying to educate like the people working in nursing homes. And something else that they mentioned was that they have some courses for family and relatives of persons with migration and dementia, but no relatives with background took part, with migration background took part to this. So they developed tailored courses for persons with migration background, and then they participated. So it was something that worked for them.
Okay, qualification and awareness raising. Thanks, Maria. Marco, you wanted to say something too?
Yeah, there is for example, a memory clinic in the north of Italy that has information material on dementia in more than 10 languages, which are the most commonly speaking in Italy, besides Italian, of course. And it's really important because it's a guide on how to manage behavioral disturbances, how to take care of the patient in other languages. So it's maybe a simple action but it's a nice impact on the daily living of patient and their caregivers. Yeah.
Yes, and I think in the end we will probably say Alzheimer Europe is an organization European-wide with all kind of original countries. So there is plenty of information how to contact the country of origin to get more information if you need to start off. Well, thank you, Marco, Peter, Tim, Jessica, Maria, for joining me in this panel session and for your valuable work. It was a lively discussion, was some technical problems, and I hope to see you in this regard, in this topic again in the future. Goodbye, and goodbye to the audience. Thanks for participating.